So, Jen, do we want to welcome everyone and get started?
Yes. Hello, everyone. Thank you for joining. I see a handful of numbers, so I do not have the names of those who joined by phone only, but I do have some names here listed. I have Hillary, the speaker, Jennifer Neal, Catherine Kolb, Karen Morris, Kristen Isaac, Lee Woodall, Lee McCormick, Liz O'Neill, Ruth Little Barnaby, Steph Rogers, Susan Noyes, Susan Wilson, Tom Stevens, Dr. Derman, and then there's several others on the phone. So we have about 26 people total here that joined. All of you guys are muted, just so you know.
So I just I unmuted myself, Jen. I'd just like to thank the Choice Project St. Louis, the staff there led by Hillary Broughton and Christina Buckle and Jennifer Mullersman, who will be our presenters today. You've got quite a few community partners here at Christiana Care and various locations throughout the state that are really interested in learning your process and your results. So thanks so much for presenting. And I think you can.
Yeah. Great. So hi, everybody. Welcome to the webinar, Reducing Unplanned Pregnancies in Wilmington Through Strategies to Promote Long-Acting Reversible Contraception. We're really excited to be doing this today, and thank you again for inviting us. My name is Jenny Mullersman. I am a nurse and have been a nurse for 23 years. Most of my background's in labor and delivery, but then I switched over to research about 9 years ago and had the awesome privilege of being part of the Choice Project. It definitely has been the highlight of my career thus far. It probably will always be, but thank you again.
Hi there, this is Chris Buckle. I've been with the project for about 7 years and currently am working on a study called the Impact Study, where we're taking some of the lessons we learned from the Choice Project and actually trying to implement them into community settings. So we'll talk a little bit about that later. Thanks so much.
Hello, everyone. Thanks for joining us. My name is Hillary Broughton, and I've been with the Choice Project for about 6 years. My role in the project is managing our dissemination activities and our community collaborations, and I'm also involved in some of our post-choice implementation work, which we'll also talk about a little bit later on in the webinar. I'm going to pass it back over to Ginny now.
Okay, so today we'd like to first discuss long-acting reversible contraception and how it should be a first-line method for all women, including teens. We're going to talk about key findings from the Contraceptive Choice Project and discuss 3 main barriers that we identified that women face when accessing contraception and strategies to overcome these barriers. We're also going to discuss projects that we're working and involved in now that are implementing the Choice Project model of contraceptive care in real-world settings. And then finally, we'll wrap up and talk about some implications and considerations for Wilmington. Sorry about that. So first of all, there are over 3 million unintended pregnancies that occur each year in the United States. 1.2 million of those unintended pregnancies end in abortion, and over 350,000 result in a birth to a teen aged 15 to 19 years old. When we look at contraceptive use related to these unintended pregnancies, we see that although 52% of women were not using contraception at the time they got pregnant, 43% of the women were actually trying to prevent a pregnancy, but using their contraceptive method incorrectly. This could mean that she forgot to take a pill every day, didn't return for her shot every 3 months, or had a condom break during sex. And although teen pregnancy has seen a recent decline, it does remain a problem in the United States. There are still 750,000 pregnancies a year, where 3 in 10 teens become pregnant before they reach the age of 20. And you can see that number is even higher among Black and Hispanic teen women. 82% of these pregnancies are unintended, and 37% end in abortion. And in addition to the numerous ways that an unintended pregnancy can affect an individual teen, the financial cost of teen pregnancy to the United States was over $10 billion in 2008. So now we're going to talk about contraception and the efficacy or typical use failure rates. For women who are sexually active and not using a contraceptive method at all, 85% of them will become pregnant in 1 year. And then you see as the list goes down that the less that's required from the user, the higher the effectiveness rate is. And so the methods at the bottom, the copper IUD, the levonorgestrel IUD, and the implant all have typical failure rates of less than 1%. So these are known as long-acting reversible contraception, which we'll refer to as LARC from now on. And as you can see, or you saw in the previous slide, the three most effective LARC methods are over 99% effective and include the LNG IUS, the copper IUD, and the subdermal implant. The first of the IUDs is the levonorgestrel IUD, currently known as the Mirena commonly, or what most people know it as. This is FDA approved for up to 5 years of use and releases a synthetic progesterone called levonorgestrel, about 20 micrograms a day. This IUD works by thinning the lining of the uterus and thickening the cervical mucus, which inhibits fertilization. It doesn't necessarily stop women from ovulating. The most common side effects of the levonorgestrel IUD is irregular bleeding or having no period at all. Almost all women using it have a substantially lighter menstrual period using this method. It is not uncommon for women to stop having bleeding, like we said, altogether, with about 30% having no period at the end of, 20% at the end of their first year, and about 50% having no period at all at the end of 5 years. There is a risk of expulsion, meaning that the uterus can push the IUD out. This risk is about 5% over the 5 years of use. And then perforation is a more serious complication where the IUD is placed outside of the uterus in the abdominal cavity. It is, however, uncommon, occurring at about 1 in 1,000 insertions. The copper IUD is the next IUD that we're going to talk about today. It is FDA approved for up to 10 years. The copper works essentially as a spermicidal agent, so it impairs sperm transport through the uterus and prevents fertilization. It is also highly effective at preventing pregnancy with a rate of less than 1%. And like the levonorgestrel IUD, fertility returns rapidly after removal. In terms of side effects with the copper IUD, there are really not very many systemic side effects because the copper IUD only works at the level of the uterus. It can usually cause either heavier periods, longer periods, or more painful periods, but this is usually most common in the first 3 months and can improve over time. We also generally can manage those heavier, crampier periods with nonsteroidal anti-inflammatories such as ibuprofen. The expulsion rate is similar to the other IUD also, about 2 to 10% over 10 years. And then, again, a similar risk of perforation with this method. And then finally, the implant is a single rod that goes into the upper arm. It releases a synthetic progesterone called etonogestrel. It is about the size of a big matchstick and provides up to 3 years of protection. And the pregnancy rate, as I said before, is less than 1%. The most common side effects include irregular bleeding, which can include spotting, no period at all, or amenorrhea, and then sometimes frequent or persistent bleeding. Nationally, approximately 10% of women are using LARC to prevent unintended pregnancies, and about 4.5% are teens who are using either an IUD or an implant. Even though ACOG and the American Academy of Pediatrics have recommended that they be first-line options. And these are all awesome methods. And just anecdotally, there was women coming out of our clinic jumping up and down for joy after their IUD insertion because they were so excited about how it was going to affect their life and that they'd be able to finish college or finish high school and achieve their goals and dreams. So that was really neat. And so then Chris is going to talk about findings from the Contraceptive Choice Project.
We should have mentioned at the beginning, please feel free to write in questions at any point, and Jen will stop us, and we're happy to address anything at any time.
Hey there. So this is Chris Buckle, and Jenny has now set the stage for why the Contraceptive Choice Project even came about in 2007. That the 10% LARC use that Jenny just reported is recent numbers. The number was far lower in 2007. So we were trying to figure out how do we reduce unintended pregnancies, and the way to do that, it seemed like, was to increase the use of IUDs and implants. So I'll just give you a little bit of a background on the study objectives. So promoting IUDs and implants was one of the first objectives of the study, and removing those financial barriers so that all these methods were available at no cost to the participant. She could also switch her method as many times as she wanted. So if she tried a hormonal IUD and didn't like it, she could switch to something else. So there were no restrictions on how many methods a woman could use during the project. And we wanted to measure what they chose, how satisfied they were with the method, any side effects women experienced, and continuation across a variety of the reversible contraceptive methods, including LARC. So women could have any of the methods that were on the market at that time, so they didn't have to choose an IUD or an implant. And then we wanted to provide enough no-cost contraception to make a population-level impact on unintended pregnancies. And some of the markers for that would be teen pregnancy, since they're so often unintended, and also repeat abortion was also another measure, because we did enroll women at two of the the two abortion facilities in the St. Louis area. And so looking at how many abortions we could prevent, from those women who were coming in for an abortion was something that we looked at as well. And the study inclusion criteria, we enrolled women who were of reproductive age, ages 14 to 45, English or Spanish-speaking women. They had to be a resident of St. Louis City or County, and that was because if we wanted to make a population level impact, we needed to be able to get those statistics on the city and county to see what type of effect that we had. And women had to be sexually active with a male partner or plans to become sexually active. And we wanted women who didn't want to plan to become pregnancy in the next 12 months, and also willing to start a new contraceptive method. So this is certainly something different that a lot of you probably see in your clinic settings. Women who wanted to stay on their method were not eligible, because we wanted everyone to be starting a brand new method so that we could compare those experiences. And a pill user who's been very happy with that method for the last 10 years is very different than a woman starting a new method for the first time. And so here are the study methods. I'm going to put that up to you. So once a woman was deemed eligible, she received tiered contraceptive counseling. That just simply means we talked about the most effective methods first, but we counseled women on all of the methods. So it wasn't biased towards IUDs and implants. We gave just basic medically accurate information on the hormonal IUD, copper IUD, subdermal implant, the birth control shot, pills, patch, ring. And we also did have some women who wanted a diaphragm, wanted to use natural family planning, and we also were able to provide those methods for those women as well. And the arrow there on the right side just kind of shows the study timeline. Once a woman was enrolled in the project, we followed the first half of the participants for 36 months. The second cohort was followed for 24 months. And we provided chlamydia and gonorrhea testing annually. And for the follow-up surveys, we did that via vaginal swab through the mail. And then we did survey women at 3, 6, 12, 18, 24, and then 30 and 36 months. And you can see that our follow-up rates were very good. So these really represent the loss, basically retention. So we still had 94% of women engaged in the project at a year, 87% at 2 years, and 81% at 36 months. And just to give you an idea of where we were recruiting, almost 70% were at our university research clinic, usually through word of mouth and provider referrals in the area. There were a lot of providers who didn't insert IUDs and implants, so they referred their patients to us. We also did enroll at community clinics like Planned Parenthood clinics, FQHCs, and the 2 abortion clinics that I mentioned. And so we have this slide up here simply to show you all of our data sources. We've gotten a lot of inquiries from around the country about how do we start our own choice project. And I think this slide is really helpful just to really visualize the scope of the project, that we probably roughly had like 70 million data points. And through screening women, all the scheduling information, all of her clinic information, the survey information, adverse events, pharmacy pregnancies, what method she's getting, STD testing, gift card incentives, and all the sub-studies that she might have been enrolled in. So this was a really complex project that just has a lot of moving parts to it. So we realized that simply trying to help people recreate it is really difficult, but we're happy to provide technical assistance and figure out how to adapt elements for each clinical situation. Okay, so now we'll just go through some of the main results of the project and our baseline characteristics. We had a lot of very young women, as you can see, the green part there in the age pie, 20 to 25-year-olds, and then a lot of 26 to 35-year-olds. About half of our population was African American. Education, almost like half of the women did have some college. About a quarter had a college degree, and about a quarter had high school or less. So you can look at these demographics and just think how they might compare to your own clinical setting. And as far as insurance status, we did have over 40% of women did have private insurance. Now, we've realized that private insurance doesn't always mean contraception will be covered. So we did have women who had insurance but couldn't get her birth control method through her insurance, so she wanted to come to us. Over 40% of women had no insurance. So this is really telling that we were filling this huge gap in coverage in the St. Louis area, that women wanted these methods or just wanted a birth control method and just couldn't get it. And then about 15-16% did have Medicaid or public insurance. And then just taking a look at socioeconomic status, we had about 40% of our population did have trouble paying for basic expenses, and close to that also received some sort of public assistance. So we were seeing a lot of women who really needed our services. And then just a couple of other variables to look at here as far as parity, that 47% of our population had never given birth before. And then, but a lot of the women had at least given birth at one point, about a quarter of a women giving birth at one time. And this is also interesting when you think about inserting IUDs and implants, because so many providers want women to be parous, and most of our almost half of it was nulliparous. So that really just goes to show that IUDs can be inserted in women who have never had children before. And then these last two variables, just looking at prior unintended pregnancy and history of abortion, really just show how our population was at risk, that 36% of the total cohort had had 2 or more prior unintended pregnancies, and almost 42% of them had had a history of abortion. So we were really reaching women who were at high risk for unintended pregnancy. And then looking at what methods women chose, the first pie is looking at the overall cohort. So 75% of them chose an IUD or an implant, which is really remarkable because the project director and principal investigator, when they were creating the study design, thought if they could get it around 10% of LARC uptake, they would be doing a pretty good job. So this just absolutely blew those numbers out of the water and was a complete surprise to them. But with almost half of the women choosing the hormonal IUD. And then looking at teens, very similar, 72% choosing an IUD or an implant, but the numbers are a little different here. We've got many more of them choosing the subdermal implant, so about a third, and fewer of the teens choosing the Paragard. And then just breaking this out a little bit more into what methods teens were choosing. The youngest teens, age 14 to 17, half of them were choosing the implant. But then you can see just the slightly older teens, 18 to 19, and you've got the majority choosing an IUD. So we suspect it's just that as women get a little bit older, maybe they've had more of an experience with a pap smear type of appointment, and that the really young teens haven't had a well woman exam yet, and that might be just a little daunting for them, and they feel really comfortable choosing the implant. And then just to look at some of the continuation information at 12 and 24 months. So the middle column there looking at 12-month continuation, and you can see that 86% of the women who had chosen an IUD or implant were still using it at a year, and almost 77% of them were still using it at 2 years. And then if you look at the bottom column, the non-LARC method, so what we would consider being the Depo-Provera shot, pills, patch, or ring, at a year, you only have about 55% of women still using that method, and then it falls to a very low 41% 2 years later. So clearly, women who are choosing the IUD or implant are keeping those methods a lot longer than the other methods. And just to break this down by age, we've heard from a lot of people across the country that they worry about inserting IUDs and implants into teens because they're worried that teenagers are going to change their mind more quickly and just want that method removed. And then that will essentially be a wasted method that could have been used for someone else. But our data doesn't really show that. I mean, teens did have slightly lower continuation rates, but they're still incredibly high. At 12 months, 82% of the teens are still using their IUD or implant, compared with 49% using a non-LARC method. And then even at 2 years, 67% of the teens still using that IUD or implant, compared with a really low 37%. So it can be really difficult for teenagers to remember to use the pill, the patch, the ring, come in to get those Depo shots. So, you know, even when broken apart by age, the LARC users definitely use their methods longer. And then this slide just shows the 12-month satisfaction, and looking again at it, breaking it down by age, the teens using any IUD or implant, 75% of them were satisfied, compared with only 42% of the teens using a non-LARC method. And in older women ages 20 to 45, 82% of them were satisfied with their IUD or implant at a year, whereas only half were satisfied who were using pill, patch, rings, or Depo. So clearly women are highly satisfied. So just to go back to the other slide, that it isn't that women are simply keeping the methods because she can't remove them herself, but she's actually satisfied with the method. And then this graph is just showing the method failure by age. So really looking at how do these methods perform in the real world, and we tracked all the pregnancies that occurred in the Choice Project that patients reported to us. And at the very top there, that bar next to the 1 is the probability of not having an unintended pregnancy. And you can see, regardless of age, women who were using a LARC method were not getting pregnant. There were so few of those. And I think the very few pregnancies that did occur were because of IUD expulsions. And sometimes women didn't know those had occurred. So that's the incredibly small number of pregnancies that we saw with women using LARC methods. But then the risk really does increase for women, and the PPR stands for pill, patch, or ring, and looking at ages 21 and over. Now you see you're at about 91% effectiveness, so about a 9% failure rate. But with the women under 21, now that has doubled. So women who are younger are definitely more likely to get pregnant using a refillable method like the pill, the patch, or the ring than their counterparts who are using an IUD or an implant. And then just to take a look at some of the repeat abortion data from St. Louis, and I don't know that the citation is on here, but I think this is the Piper article from 2002 in the Green Journal, where we obtained data from the Missouri, I think it's actually the Department of Health and Senior Services, and looking at women who reside in Missouri at the time of abortion. So they collect those statistics. And repeat abortion is just measured as ever having a previous abortion. And we compared the repeat abortion rates to Kansas City, which is very similar to St. Louis demographically, and also non-metropolitan Missouri. So basically Kansas City, St. Louis, and then everything else was in this kind of non-metro category. And Kansas City also just has one abortion clinic. And, oh, there we go, there's the citation. So looking at this graph here, the repeat abortion rate went up in Kansas City and went up in non-metro Missouri, but did go down in St. Louis City and County right around the time when the project was going full steam. So of course we can't completely say that this is caused by the presence of the Choice Project, but if you look in the paper, the sample size calculations and the power indicated that we did reach enough women who were at high risk for unintended pregnancies that we should have seen a population effect in the city of St. Louis and County. So that these numbers are just bearing that prediction out. And then also looking at teens in this study, the unintended pregnancy rate and abortion rate dropped significantly. So looking at the national average in 2008 of about 158 per 1,000 teens, sexually active teens becoming pregnant, our study participants, it was 34 per 1,000, and as the abortion rate nationally is about 42 per 1,000 teens, ours was only 9.7. So again, this is because most of our participants were using the most effective methods of contraception, so those pregnancy rate and abortion rates were just significantly reduced. And so just to recap, the main findings are that IUDs and implants are associated with higher continuation and satisfaction than shorter acting methods, and that is true regardless of age. LARC methods are associated with lower rates of unintended pregnancy. And increasing LARC use can decrease unintended pregnancy in the population. Okay, and I believe that is my last slide, and I'm going to turn over the remaining section to Hillary, who's going to talk about, so how did we actually increase LARC uptake?
Jen, did we have any questions come in on that last section?
No questions as of now.
Great. Just stop us at any time. So a lot of people ask, what are the big secret ingredients for increasing LARC uptake? How does that happen? And what we found is that there's really three key ingredients. First is just education regarding all methods, especially LARC methods. And second, access to providers who are willing to offer and to provide LARC. And then the final piece that's important is affordable contraception. Contraception of all kinds needs to be made available to all women with a low cost. So let's go ahead and talk about our first strategy here, which is providing education. So originally with the Choice Project, when the first participant came in to enroll, and Jenny actually enrolled her, Jenny was really surprised to find out that she didn't have any sort of a baseline knowledge about what contraceptive options were available to her, and really had zero awareness about LARC in general. So at that point, the project director said, well, Jenny, you just have to tell her about her options. And then after that, Jenny really worked to develop a training program, which included a counseling framework, a standard script, which would be given to every woman when they came in for their counseling, a contraception 101 lecture, which was done by one of our medical doctors, and then the counseling and medical history forms, so the instructions on how to use those forms within the counseling session, and then also a testing and observation, so a quality assurance protocol. All of our counseling and choice was done by non-clinician research assistants. We had 53 different research staff and volunteers which provided counseling across the 4 years. 14 were medical students. And then it's important to note most of our research assistants really didn't have any sort of a background in health. Most of them did have a 4-year college degree, but just across different disciplines. And we did have a few research assistants that also maybe had a 2-year degree, associate's degree. When we talk about our contraceptive counseling, there's really a couple of different components to it. First, the research assistant met the patient in the waiting room, got her height, took her back to the lab and got her height and her weight and her blood pressure, and then took her back to one of the 3 different private counseling rooms to do her session. So this slide here shows what that counseling room looks like. You had the counselor on one side and the patient on the other side. Notice that obviously that means that the patient is fully dressed for her counseling session, so she's comfortable. The non-clinician counselor was in, just her professional attire, no white coat, to really denote that she was a peer. She didn't have any sort of a medical degree. We also had different visual aids that we used throughout the counseling session. So we had different models to show what the, where the IUD goes, where the arm implant goes, and what that feels like under the skin. We had a calendar so she could recall different dates, such as her last menstrual period or the last time that she had sexual intercourse. And then I'll point out our visual aid in a little bit more detail here in just a minute. So going back to this other slide. So the counseling session, as Chris mentioned, what the counselor did is provided information about all of the reversible contraceptive methods from most effective to least effective. So first she talked about all of the different LARC methods, and then she went down the list. And the main things that she talked about with each method were how long it lasted, the different side effects that she might experience, the effectiveness rates. So then that counseling session lasted on average about 13 minutes. So after the participant decided what method she thought sounded like a good fit to her, the counselor would actually leave the room and go present her medical information to the clinician. So at this point, the clinician really had 3 different options. She'd either say, yep, great fit, let's insert that method today or get her started on that method today. She'd say, oh, this LARC method's a great fit for her, but given her medical history, it's not a good day to insert it. So she'd bridge her with a refillable method and bring her back for a second appointment. Or then the third option would be if the patient wanted to use something like a refillable method, a depot shot, pills, patch, or ring, she'd get 2 months worth to start, and then also a prescription where we had a partnership with our local grocery store pharmacy, and so she would get a Choice Project insurance card almost, and would be able to go and pick up her prescription every month. So usually the counselor had enough background knowledge on different contraindications that if the patient talking, had different medical conditions that the counselor recognized would keep her from getting a certain method, she'd be able to sort of weed that out, not making a clinical decision, but saying something such as, oh, well, if the clinician says this isn't a good method for you, what would be your backup option? Or the same thing, if she didn't think it would be inappropriate for same-day LARC insertions, she'd be able to say, great, and if the clinician doesn't think that this is a good method to insert today, what would you be comfortable going home with today? And then sometimes, several times, the counselor wouldn't be able to decipher all of the medical history. So she would actually have to go back and forth between the clinician and the patient quite a few times until it was an agreeable decision. So once that contraceptive decision had been made, the counselor actually brought back a method fact sheet to review with the patient and explained how to use the method. And we found this was really important because so often if a patient does choose a refillable method, such as pills, patch, or ring, maybe she's never had any formal guidance on how to actually use them. So being able to walk her through that first time of inserting a Nuva ring, or walk through, oh, here are the stickers that can go on the pill pack, or here's a different app here's an app you can use on your smartphone that'll send you a daily reminder. So anything we could do to really just sort of heighten her chances of success with the refillable methods, and to heighten her knowledge about what to expect as a new LARC user, especially regarding different bleeding patterns. So this is our menu of contraceptive options, which is our main visual aid that's used in the counseling session. It was laminated and placed in front of the participant, and the counselor actually could use it to sort of go down the list. So it really made it apparent, oh, these are the most effective methods, and then we're going to move down in effectiveness a little bit. So it helped guide that script, but also gave that patient something visual to look at, since we all learn differently. What we think is really neat is that we've actually seen different organizations nationwide that have taken our menu of options and made it so that it can fit their own settings. So this example is from Indianapolis Healthy Start. And as you can see, they added in their own logo on the bottom. They used their own colors. And then we really like too how they put down the side, most effective, moderately effective, least effective, emergency only. And they added in their phone number, their contact information. So we highly encourage different organizations to use this and to adapt it to fit your needs. So some of the key components to counseling, like I mentioned, LARC first, so using a tiered approach to counseling and making sure that women know that there are different effectiveness rates for different methods. Eligibility is always based on medical history, not just on some sort of a preconceived notion. And there was a clinician that always made that judgment. And third here, patient choice is the priority. So even if a patient had a history of unintended pregnancies and she decided that she wanted to use one of the least effective methods, that's her choice. Our role was to inform her of her options and for her to make that choice. We also found that the script is really helpful to keep information standardized. Like that last slide that had the amount of staff that we had providing counseling, we wanted to know that each participant was getting an equal experience. So every woman heard the same script from 14 to 45 years old. And then also discussing what to expect with the method and the use of models. So given that the IUD and implant are methods that a lot of women haven't heard of, it was important for them to be able to see where the uterus is and where that IUD sits in the uterus, or how that implant feels underneath the arm. And of course, back to the bleeding, it's really important that a new LARC user knows exactly what to expect. So if she does have some spotting, that she's not just immediately concerned, oh, this method's not working, or something's wrong with my body. So making sure she knew what to expect in that first week, in the first month, in the first 6 months, and also telling her we can't exactly predict what your bleeding might be with, like for example, with the implant. And then also knowing that she could call us at any time if she ever had any question. There was no stupid questions. If she just needed reassurance, we were happy to provide that. And then also a key component for our choice counseling was using our non-clinicians as counselors. This freed up clinician time so that they could do more insertions in the same day. Like as I said, the average being about 13 minutes. And it was a great role for our research assistants. We absolutely loved providing the counseling and that opportunity to talk to women about the methods. So it was really quite beneficial for us to be able to do that. And as we see this in being replicated in community settings, we are exploring at different sites how they can use existing health educators or medical assistants or med techs and what that might look like in their setting. So after the Choice Project, we did a survey of about 100 participants to find out what they learned and what they liked about Choice. And what we found is so many responses had to do something with the counseling or the education. So one woman said that every woman has so many options. She has choices in birth control, options for pregnancy. I finally feel like I have a choice in life, and that is so great. And then another woman said, I learned so much all about the different methods that are available to women. They've never been presented to me like that. So we really are proud of the counseling that we did at Choice and the impact that it had on women and their healthcare decisions. So just in summary, for the counseling, the first strategy of removing the education barriers. So doing tiered counseling from most to least effective is essential for improving LARC uptake. Non-clinicians can be trained to effectively deliver counseling, which benefits both the provider and the patient. And then contraceptive counseling can be creatively integrated into your practice. So we recognize that not every site's going to have the luxury of having 70 different staff members that can provide counseling, or this long training period of how to get the counselor trained. But we do think that different components can be integrated into your practice. And like Chris mentioned, we're happy to provide technical assistance with figuring out what that could possibly look like in your setting. So when we talk about our second strategy, it's removing the access barriers. So some of the common barriers to LARC access that we see are providers are not trained to insert IUDs and implant. IUDs got a bad rap, and a lot of back in the 70s, and a lot of providers, because of that, went through medical training without there being a device on the market, so no reason to be trained, or there's just a lot of hesitancy in general given the painful history. So so that's one barrier, is just providers not being trained. Another barrier that we see is that there's misinformation regarding who's an appropriate candidate for LARC. Some providers think, well, only older women who are done with their childbearing and have had children are good candidates. Some say as long as you've had a child. Some are not willing to provide the devices at all for fear of a non-return to fertility. And then another barrier we see is the requirement of multiple visits prior to the device placement. A lot of times this is because there's not that device in stock, or there's a lengthy pre-insurance verification approval. And there's just plain misinformation about when that LARC can be inserted. And a lot of providers thinking, oh, it needs to be inserted on your period. You need to be abstinent for a month beforehand. And really, when we require women to have all of these things done before they can actually have their IUD inserted, or to have these multiple visits, we're putting up so many barriers in terms of maybe she could only find transportation today. Maybe she needed to take a day off of work to be able to make her appointment. Maybe she can't find childcare. So we're really putting her at risk for an unintended pregnancy just by putting these barriers up. So that's why in Choice we were so big on, even if she was not eligible for that LARC insertion today, we wanted to make sure that she went home with something. Some of the LARC eligibility myths that we hear, like we just discussed, that they're only for Paris women, which we know is not the case through Choice Project data and also just through evidence-based recommendations from the CDC. This myth that an insertion must occur on a period, and that really just stems from making sure that being 100% sure she's not pregnant, because that period is visible. But we also know that there's evidence-based tools and algorithms that can rule out an unintended pregnancy based on what point in the cycle she is and when her date of last unprotected sex was. The requirement of a pap smear is an unnecessary barrier that sometimes is put up. We also hear that LARC methods are not appropriate for teens. And 72% of teens in Choice Project chose a LARC method and absolutely love them and love the freedom it gives them and love that they don't have to remember, sports practice and taking a pill or something. It's just a lot to remember for them. And we also saw that this did not it didn't change sexual behavior just by having access to these methods. We also sometimes hear that providing a LARC to women postpartum is unacceptable because it'll interfere with breastfeeding. However, the CDC recommendations actually show that that's not the case and that these are acceptable methods to initiate immediately postpartum. We also don't think that it's recommended that it's evidence-based medicine, that it's not necessary to have STD results back prior to inserting LARC. An IUD can actually be inserted that same day as long as there's no active cervicitis. And for some reason, if her test did come back that she was positive for chlamydia or gonorrhea, she could be brought back in, treated, and there's no increased height for pelvic inflammatory disease. And then also we hear that this fear that women will have LARCs removed too soon, which I think that the Choice Project data really shows that that's not the case. And we just don't see those people that are discontinuing pills, patch, or ring. So really trying to keep that in perspective, that the only people we're seeing that are coming in to discontinue contraceptives are LARC patients. And so it feels like that's a heightened ratio, but it's really not. So in terms of next steps to remove access barriers, the first one is figuring out how to stock LARC devices so that if a patient comes in and wants the implant, that she's able to get it that day as long as it's medically appropriate. Another piece is creating LARC-friendly exam rooms, so making sure that you have all of the tools that are necessary for an implant insertion or for an IUD insertion that are stocked and ready to go, so that if a same-day insertion is a possibility, that the medical assistant or the clinician is not scrambling around trying to get things ready for that insertion. And we've also seen sites that maybe they don't have enough exam rooms to make them all ready. They actually just do LARC packs. So they have a little cart that goes from room to room that if the doctor says to the medical assistant, I need something for an IUD insertion, then she can actually just bring back that cart to the room. It's just a really nice, seamless process. Another thing that must be done for removing these access barriers is training providers. And if providers are not excited or they're hesitant about being trained to insert either IUDs or implants, creating some sort of a rapid referral system internally so that non-inserters have someone that they can send the patient to immediately in order to be able to facilitate that same day insertion. And we've seen through the community that some providers are more than willing to insert implants, but maybe not IUDs. So really figuring out, okay, who's inserting what, who is wanting to be trained to insert what, and how can we facilitate this? And then finally, the last big one is using CDC tools to guide clinical decision making. So using the how to reasonably rule out an unintended pregnancy criteria within the U.S. selected practice recommendations, using the U.S. medical eligibility criteria from the CDC to decide if a patient is a good method or not for, or a good candidate or not for a contraceptive method. And then finally, our last strategy is removing cost barriers and finding a way to make LARC affordable. So we always say if you can get support from private foundations, fantastic. It's going to make your work a lot easier. But we also are sort of learning through different community projects that it's not necessary for the LARC truck to come and deliver 100 different methods that same day. I think it's there's really different ways that you can work within your system to figure out how to make this happen if a private foundation isn't willing to support your LARC work. So first, with the Affordable Care Act, more and more women are insured than ever, and contraceptive coverage is mandatory. So we're seeing that through Medicaid expansion and through the use of Medicaid family planning waivers. So first, finding out, does your state have a Medicaid family planning waiver? What are the income requirements? Who can we get enrolled in this? And facilitating enrollment at the clinic level. And so it's making it so that the woman herself doesn't have to be proactive, because she might not even know that this exists, but the clinic itself being proactive and figuring out how to get expansion or the waiver to cover more women's contraceptive needs. And then also using Title X only as a payer of last resort. So really thinking through, okay, can we use some of these patient assistance programs through TEVA or through Bayer? If we can't use those, are they eligible for Medicaid family planning waiver or Medicaid expansion? Still not. Or they still fall into that uninsured category, only then using Title X funds. What we see too often is Title X, once that money is dispersed at the beginning of the year, it just automatically is going to the first patients that walk in the door when those patients could have been facilitated into a different plan, and then you run out of money. So really trying to figure out how that works. And then we've also had a lot of success in involving the chief financial officer. So at baseline, being able to look at your billing and coding and your reimbursements and saying, okay, how much are we being reimbursed for a marina? How much are how much are we being reimbursed for an implant? How much for the Paragard? And then looking and seeing, are you making money or are you breaking even? Or are you losing money? And we've actually done a LARC costing tool with several different sites, and we're finding that really sites are, for the most part, making money off of LARC devices. And then also when we see that the sites are losing money, we look and see, okay, well, let's look at your insurance contracts. Maybe they have not been renegotiated in a while, which is a need now that these new methods are becoming more and more popular. And also, are you billing and coding for everything that you can? Are you billing and coding for pregnancy tests, for STI tests? So really maximizing the amount that you can get back on each patient can help cover that LARC cost. And then finally, this one we're so excited about is that now that the Liletta is out, the Liletta is a 5-year hormonal IUD that's similar to the Mirena. However, it is available for at 340B costing for $50. So we think, this literally just came to the market in April. So I think it's going to make a huge impact on women that desire hormonal IUD and sites being able to provide that. So now I'm going to hand it back over to Chris. I'm sorry, no, I'm not. So now we're going to talk about implementing choice in community settings, and we're going to talk about 2 of the different projects that we have going on. And we're also going to mention the resource center that we built. So what we found after Choice Project had ended, and even while it was still going on, is that so many community sites, so many community networks like yourselves were reaching out and saying, how do we do this in our own setting? Like, what did you do? What's the magic? And so it got a little tiresome sending out individual emails. So we decided the best thing to do was to create an online resource center. So I don't know if many of you have explored, but www.larkfirst.com has pretty much all of the different materials that we've created for the Choice Project and that we used in the Choice Project. So all of those evidence-based clinical decision-making tools that we talked about. We have a ton of different Choice Project produced videos, and we've divided it into 5 different modules. So the evidence, which includes things like this PowerPoint that we're using today, contraceptive counseling with all of our visual aids, and our training program, and everything revolving around contraceptive counseling. And we have advanced practitioner resources, patient management, and effective staffing and management. So this is really helpful as you move forward. All of the tools on this are available that you can download either in PDF or in Word or PowerPoint form. You can modify anything to fit your needs. Like I showed the example of the menu of contraceptive options. We strongly encourage it, and really the only thing we ask is that you show us what you did so that we can use them in our future presentations, and just it's really exciting for us to see them be used in community settings. So our first project that we're going to talk about, that it's sort of a post-choice implementation project, is a partnership between Ciccatelli and Associates based out of New York City. They're a capacity building reproductive health group, and us here at the DCR at WashU. And really, this partnership, called the Contraceptive Action Plan, draws on key findings from Choice, and then also with Ciccatelli's experience working with healthcare providers nationwide. So the CDC funded us to do a 2-year pilot. So the first year we implemented in one Title X standalone and one federally qualified health center in Springfield, Massachusetts. And then we're currently in our second year, and we're implementing in a federally qualified health center in Indianapolis, in Milwaukee, Wisconsin, in Lima, Ohio, and in Columbus, Ohio. And what this really is it moves beyond just the Choice Research Center, because we recognize as a standalone contraceptive clinic, you're missing out because on some things. For example, every woman that came to us was motivated to contracept. So this almost takes it a step back and says, well, how can we identify these women that are not yet motivated to contracept, but catch them when they're in for a preventative health visit? So the CAP contains a series of different online e-learning modules for all clinic staff, and implementation tools and job aids. And really some of our first year we saw big successes. However, as a pilot with only 2 clinics, it was more of just a learning experience and helping us sort of guide the second year and how to modify our materials. But we did see an increase over 113% in same-day insertions, and a large LARC uptake in the other site as well. Some of the best practices that are coming out of this partnership that we have with Ciccatelli is that it's imperative that any sort of a LARC initiative starts with the health center or the network leadership. Contraception has to be on that quality initiative agenda, which is really hard when there's so many different competing items, such as chronic disease. But figuring out how can we intertwine this, or how can we phrase it so that we see how important it is. And we're seeing a lot of sites are actually really phrasing it as an infant mortality initiative and a reduction in infant mortality. Another best practice that's coming from this is piloting with a small improvement team. So instead of trying to train 20 clinicians at once to insert LARC and 50 different medical assistants, really finding, okay, who are our clinicians that are eager to be trained, and who are our MAs that are a good team to fit with those providers, and starting small with them, and then starting a rollout really small and then moving it bigger. Also, this work is phased, so we're not just trying to just immediately go in and say, okay, now it's time to be trained and to do this and to do that and start stock LARC devices and all of this. So really making it just baby steps. And then also focusing on performance measures, which we're finding with a lot of sites when we asked them to collect some of their baseline measures, and they had, no idea that they were missing so many different women that were not desiring pregnancy, but also not using contraception. And then just constantly looking at those performance measures, it really keeps the momentum going, and keeps clinicians and other staff excited to keep working on a contraceptive initiative. Now I'm going to pass it back over to Chris to talk about the impact study.
Hi there. And so IMPACT, we cheated a little bit with this acronym, but standing for Innovative Model of Patient-Centered Contraception, funded by PCORI, or the Patient-Centered Outcomes Research Institute. And for those of you who may not have heard of PCORI, it's technically a nonprofit organization created by the Affordable Care Act, and they focus on funding research studies that really do help with patient outcomes in various disciplines in medicine, and especially with communication between providers and patients, and making sure that patients have more involvement in their health care. And so what we're really trying to do is implement aspects of the choice model in real world clinical settings. We have 2 sites in St. Louis who actually also were sites for the choice project. And then we have a site in Memphis as well that we're working with. And we're trying to evaluate the intervention itself, and which I'll describe, and also the implementation outcome. So how did this work with the staff implementing a research project? So we're really trying to take our results and see, can we disseminate them and implement them in the real world, because that often doesn't happen. People do a research project, they write the manuscript in the academic journal, and then everyone goes back to a new project, and those results never actually trickle down into the real world. So that's what we are trying to do very aggressively. And the intervention in IMPACT is similar to the choice project. We're looking at unintended pregnancies and also method choice. Now, we're not providing all the methods for free, and this is actually a time-controlled analysis where the first half of women simply received contraceptive counseling that was provided by a clinic staff member, like an MA level type person, or maybe even front desk at one of our sites. And just to see, does the LARC uptake increase, or at least the method women want, does that increase if someone has provided them with standardized counseling? Now, the counseling is definitely very different than it was in the choice project. As Hillary described, most of our counselors did have a 4-year college degree, and some people had advanced degrees. So we had a very highly skilled workforce here at the Choice Project, but we tried to just strip it down and see if a clinic staff member could provide just some basic education on the methods. And so we provided intensive training for those people. The clinics do receive salary support for these folks, so they are 100% employed for the project, and they do all of the research aspects as well. So they're doing the informed consent, survey administration, screening people for eligibility. So then the second phase of folks enrolled in the IMPACT study received that same contraceptive education, but then we did very targeted clinician education sessions, talking with them about IUDs and implants, some of breaking down those barriers that Hillary described, increasing same-day insertions, and also having some IUDs and implants available at no cost for women who would want one of those, and having them on the shelf. Because in St. Louis, I don't know if you all have this issue on the East Coast, but many of our Title X clinics and federally qualified health centers use third-party pharmacies to purchase the actual device. So like for Medicaid, because the clinic doesn't have the money to buy those devices out front and have them on the shelf, they go through this third-party pharmacy who then purchases the device, and then it is shipped to the clinic. And that creates many barriers for women coming back into the clinic. So having these methods available, we have basically said, regardless of her insurance status, insert the method that we have through the study, and then we're tracking the billing data. So for women who do have public or private insurance, the clinic site is then billing those insurance companies to see just what Hillary said. They had no idea what the reimbursement rates even were. They were always too scared to try it because it seemed like they were definitely going to lose money. So we're going to be working with them on that LARC costing tool as the study concludes to try to see how we can keep these methods on the shelf. And in St. Louis, where this stocking issue has been primarily a huge problem, we are seeing a LARC uptake that has far surpassed our expectations. So we can't keep these methods even stocked. I mean, we've had to buy so many more methods than we thought that we would need. So these methods are very popular. And I think this project really demonstrates how each clinic is so different. In St. Louis, it was stocking was the big problem. We had many providers who were very passionate about providing IUDs and implants, completely willing to provide them for other clinicians who weren't inserters. So I've seen a lot of lovely teamwork happening where a woman who is coming in to see a provider who might not be an inserter, but someone else has stepped in and says, I'll insert that IUD for you, and just so that woman can get that method same day. But in Memphis, they actually have an organization called the Step Ahead Foundation, which does provide IUDs and implants and actually the birth control shot to women who don't have insurance. So they have those methods on the shelf, but we're not seeing a tremendous LARC uptake. So we think there it might be more of a clinician education piece that is holding them back from seeing higher LARC numbers. So we are still enrolling currently. We hope to wrap that enrollment in about 2 months, and then we'll have some interesting results to show. And now the question is, how do we keep that sustainable, and how do we keep those gains going in these clinics once the study has concluded? So that's exactly what we're working on now. Okay, so then as we're wrapping up here, we really want to talk about you guys and considerations for Wilmington and what, if anything, we talked about will help you in some of your goals. And so, I mean, the first thing that we always start with is, what is the goal? Like, what are you all trying to accomplish? And sometimes we help groups think of short-term goals, the low-hanging fruit, and what's a longer-term goal that might take more buy-in from different groups and more collaboration. And then also just thinking about who are your key players in the sites who would be involved in some of these clinical components, and how are these different community organizations going to collaborate? As we saw from the email, that you all have quite a wide range of expertise on this call, and that's really exciting to see that you all could come up with a way to increase IUD and implant usage among your different populations. And just thinking, if you were doing a research project, what outcomes did you want to see? Is it going to be pregnancy? That's difficult to measure, though. That's why we're doing the individual level data like the impact study. Or is it citywide statistics? Is it clinical statistics? And just how are you going to measure success is one thing to really think about. So Jen, I don't know, are there any questions out there that, now that we've gone through our slides, we'd love to hear from you all and just see how any of this information might be relevant to what you all are doing out there.
Looks like we don't have any questions in the chat function, but what I can do is unmute everybody and see how that goes in terms of feedback.
Are you able to hear me? Hello? Maybe I need to speak softly. This is Richard Derman at Christiana Care. So have you guys done a cost effectiveness analysis? And additionally, what was the cost to initiate your first 3-year program?
So difficult to figure out, because everything was at no cost, basically. I don't remember what the official budget was, but it was over $20 million for this study. And of course, a lot of those costs were for participant incentives. They got a gift card at every survey. So things like that normal clinic situations wouldn't have as part of their budget.
Staff.
Yeah, and we had a huge staff, which was also part of it as well. So we don't have an exact cost effectiveness study. I know folks have really tried to do that, but because the just the way the project was structured didn't mimic the real world very well. So that's hopefully something that we're going to be able to get from some of these real world studies and really looking at clinic data and seeing what's the impact.
Thank you.
This is Karen Morris. Can you hear me?
Yes.
Okay, I guess I have two questions. Following up on Dr. Derman, do you have any cost data from the real-world sites where it's being implemented or budgeting?
We don't at this point because we're actually still actively collecting that data. So I think when the study concludes in a couple of months, at least for the impact study, we will have some of that. And I really hope that I think we can publish a paper on just that aspect of the project. And Hillary, I don't know, do you have any data from CAP?
We won't have any that we can share until after October of this year.
So you think your timing is at the end of the year?
Yeah, at the end of this year.
And then my second question is, given that you have 70 million data points from your own project, have you had a data person come in, a statistician, to analyze correlations and connections and, maybe solve some of these real-world problems with the data analysis function?
Yeah, well, I'm actually the data manager for the Choice Project too. And so we have, I don't know actually what our publication number is at this point, but it's a lot. So over 50 publications from the Choice Project. And so we wouldn't be able to really get at that cost effectiveness data. People really did try to do that, but it just wasn't a good approximation of what happens in the real world. But so through those 50 plus publications that are still coming out, we are still constantly looking at different questions. And we do have a statistician who is part of the study. And so she's been working on the Choice Project really since the beginning. And so we will look at different data questions as they arise and clean and analyze that data. But of course, it's hard to get to everything. And there are some things I think we've realized, not all of the data that is included in those 70 million data points is really usable data. Some of it is just, contact information and clinical information that might not be exactly related to a specific question.
Thank you.
It looks like Liz O'Neill has used the chat function, and her question is, did you do a provider survey to assess knowledge, attitudes, experience of your provider community? If so, can you share the survey tool? What did you learn? And did you do a patient survey for baseline knowledge?
So the Choice Project did do a provider survey. I believe it is it Madden?
I think it's Ladkey.
Ladkey, okay. And we can find this reference for you. And it's assessing provider attitudes. And this was done,
2007.
Okay, so 2007, right around the time that the Choice Project was gearing up just to find out in our area what the provider attitudes were. And so you all could definitely look at that. And I am not sure, I haven't looked at that paper in a long time, if the actual survey is included in that or not.
But we can check with our principal investigator on that. And if they're willing to share it, then we can definitely send it on to you all.
And something that we did for the Impact Project is we did do qualitative interviews of all members of staff before we even started the study, just to find out what are their attitudes, what are their roles, who are those key players, and have a wealth of information qualitatively. We have not analyzed that yet. It was really just to help us figure out how we were going to try to implement this study in each setting. But then part of our implementation evaluation, at least with the Impact Project, is we do interview all of the clinic members involved in the project, including providers, at the end of the first phase. We're going to do it again at the end of the second phase, and then 6 months after enrollment is completed, just to find out what their experiences were, what their attitudes were. We did have the providers do an online, I don't know if you're all familiar with RedCap, but we did an online emailed survey via RedCap. I'm sure we could share that. I could talk to my principal investigator just to assess anonymously just levels of comfort and who was inserting what and what their training was, so that it could help guide our provider trainings, which we did at the beginning of the first phase.
Jen, I think you have 2 more questions in the chat box.
Yeah, I was looking at them. So one from Susan Wilson. She said, just to clarify, all counseling and LARC insertions were done at Washington University. If so, how many counselors did you have and how much time was spent completing all the staff training before the project was initiated?
Do you want to talk about off-seconds?
Oh, no, go ahead.
So I think the first part was, did all the counseling occur at WashU?
Insertions.
Oh, okay. Yeah, so when women were enrolled at those offsite clinics, as in this slide, which showed we enrolled at 8 community clinics and 2 abortion clinics, the women were enrolled there. We liked them to receive counseling from the provider they were seeing there, but we also, our counselors who were enrolling did have to fill in the gaps quite a bit. So we would make sure that women did receive the same amount of counseling, that women who were enrolled at our WashU facility would receive, but the insertions would happen at her outside clinic. So not everyone had to come to our facility for those insertions. So it really was dependent on the clinicians who were at those community sites. But our research assistants brought a giant bag with all of the methods because we didn't know what enrollees would choose. So each research assistant had like 3 Mirenas, 3 Paraguards, 3 Implanons, and a whole bunch of pills, patches, rings, depots that could be given out.
And as far as the training piece goes, with the Choice Project counselors, it was over about an 8-week time period, but that was including all the research components. And then so recently we opened up a clinic trying to replicate the Choice model again with using insurance and Medicaid expansion, and realized we don't have the luxury of taking 8 weeks out of a training period to train people, nor does anyone have that 8 weeks. We realized we, had it very easy. So we have pared it down to 2 weeks. Like Chris will probably realize too, and she trained all the counselors for Impact too, but the ability to observe plays a huge component of it, especially with staff turnover. So we've pared it down to about 2 weeks, but giving them time to observe and stuff is really important.
And I think something that we've finally learned to articulate is that our training was ongoing. It was just part of the research assistant's day-to-day activities. It wasn't like, okay, you're receiving training at this discrete period of time, and now you're going to be set off on your own and no one's ever going to observe you again. And the way the Choice Project was structured, the woman who enrolled the patient was a different woman who provided the contraceptive counseling. So we always had 2 research assistants in the room with that patient. So we were constantly observing each other, and we were managers on the project, and we also often enrolled, and so we would be observing our research assistants that we were managing doing the contraceptive counseling. So it was really, and we also had clinical updates with providers monthly. We really tried, we just were completely immersed in birth control, and we did have the luxury. That was the only thing we did. We didn't provide pap smears. We didn't provide well woman care other than STD treatment. Really, birth control was it. So we were allowed to have our research assistants completely immersed and focused on that.
It's also really good to have a person or persons identified as a safe place that counselor can turn to for when they have questions. That no question is stupid. This is a team-based approach, and just to keep those skills going, and that new questions that the answers don't get made up. That they're really evidence-based answers.
So we have about 4 more comments in the chat function. I believe we may have already addressed Tom Stevens' comment, but his was, you stressed the benefit of using non-clinicians for counseling. How long did the typical training take for an individual staff member? How did you do this training, train the trainer, online, etc.? So you guys just talked a little bit about that, but you want to answer further.
Yeah, I mean, maybe some other components that we didn't mention is we had multiple test outs to make sure that the knowledge was accurate. Our research assistants did an oral exam, basically, with our clinicians, and just to make sure that our clinicians felt comfortable that these research assistants were providing accurate information. We had a checklist, and all of this is on the LARC First website that Hillary mentioned under contraceptive counseling. There's a whole outline of how you could do a training program, some of the materials that we use, and just trying to think of keeping that training program sustainable so that you're not training a person, spending a lot of time, and then they leave. You want it to be something that's integrated into the training for new hires so that you always have a way to make sure that you've got educated staff members.
Stephanie Rogers said, did you experience any resistance to using non-medical staff for counseling? And if so, how did you address this?
I'm assuming you mean from patients, and no, we did not at all. Patients actually, quite a few expressed, just complete content with speaking with a peer face to face. Most of our counselors were women. Were all of them women? All of them were women. So we didn't experiment with any gender differences on that, but no pushback at all.
And as far as pushback from any kind of providers, we gave them, they knew what we were teaching people, and so and then it became a thing that the providers were really grateful to the counselors and excited about the education that the women were receiving, and that basically by the time they saw them, the woman knew what she wanted, knew about the side effects that could possibly be happen, and all the aspects of that.
And just to add on, one important piece of the counseling component that we didn't mention is we really hammered home for all of our research assistants, know what you don't know, and included in the test outs were always some sort of really difficult questions to see, how are they going to respond? Are they going to make up an answer, or are they going to be able to say, I don't know the answer to that. Let me ask a clinician and get back to you. So that was a really important component.
Kristen said, how did you make sure that all materials were at an appropriate reading level since you were dealing with such a large population with varying education levels?
Well, actually, pretty much the entire enrollment was conducted in an interview format. So the research assistant was reading it to the enrollee, and there was very little that the participant had to read. Now, of course, there's always the informed consent issues, but we followed the guidelines for Washington University and whatever, the boilerplate language is. That's a set reading level. But we always offered to read the consent form to her as well. So we didn't have, there really was very little that participants had to read to be in the project.
Okay, and the last comment in the chat that we have from Jane Bowen, there has been concern expressed about inserting LARCs in young teens without knowledge of parents because of fear of reaction from parents or guardians. Do you have any experience or insight about this?
In the Choice Project, because contraception, this was 2007, the principal investigators did decide that they wanted to get parental consent to participate in the Choice Project, with the caveat that we could waive parental consent in some cases if the teen felt threatened or anything by their parent or didn't know where their parents were. And I think we only waived parental consent for about 4 times.
Out of 1,400.
Out of 1,400. That being said, there was an instance, and I understand as a parent, and I've been a parent of teenagers. There was one evening when a mom came in, and she really did not understand why she didn't get to decide what her daughter wanted, and mostly it was just me empathizing with her, and understanding this is really hard watching your kids grow up and that they get to make their own decisions. And I know it's your insurance, but it's really important for her to feel empowered. And by the end of the conversation, the parent was more than willing to have her child choose what was best for her. So that was one instance, but for the most part, parents were really excited about their children being able to, that this was one aspect of their life that they wouldn't have to worry for their future.
Mm-hmm. And for the impact study, we have the principle that teens can get contraceptive care without parental consent. I mean, they can go into any clinic and receive birth control methods, and they don't have to tell their parents. So we actually don't require parental consent for our study. The parent can be involved with the discussion of the research project during the informed consent, but they can get those methods in the real world. So our guidelines don't necessarily have to be different. Another thing is we've seen so many really supportive parents. I mean, even in the impact study, I've had moms and daughter enroll. We have it in Choice all the time, where a mom bring all three of her daughters in at once to enroll because they just want their daughter to have the best care. And
we had a grandma, mom, and a daughter.
So I think there's a lot of parents who are actually very supportive, but they're also uneducated themselves. Like Jenny talked about, it was just allaying some of these fears and educating the mom about the methods. And many mothers and grandmothers remember the Dalcon shield, and they don't have a good connotation with IUDs. They certainly don't know what the implant is, or they're thinking of the Norplant, which caused some problems for people. So it's just about educating people about what is available now. And I think overall, most parents are very supportive.
Looks like we don't have any more questions in the chat function. If anybody wants to unmute their mic and answer or ask any more questions, we have about 4 more minutes.
And we're also happy to answer questions later on. I know sometimes it takes a little while to think about some of the things that we presented and how this might impact your site. And we're thrilled to help you all going forward if there's anything else that we can do, if there's something that, that comes to you later on.
This is Liz from Christiana Care. I just want to send a heartfelt thank you for an excellent presentation, Hillary, Christina, and Jennifer. You've been great to work with. I think we all learned a lot today, and we are in the big learning phase. There are some clinical initiatives happening, throughout our hospital and at the FQHCs that have participated on the call. We are in the beginning stages, and you did pose a lot of key questions that we are discussing within our institutions and among community organizations. And we just felt that this was the best way to start with your technical assistance, is getting this great overview. So I'm hoping that we can invite your team to come on site in the near future when we're a little further down the track addressing our short and long-term goals. But thank you so much for today.
Absolutely.
Thank you.
Thank you all for participating. We look forward to working with you further.